All right, let's talk about some treatment options here. We talked about non-pharmacologic treatment. What are the basics that all primary care physicians know of in terms of, and that are relatively straightforward to initiate, the basic treatments for osteoporosis?
I think most primary care physicians, if you ask them, the first class of medication that they would mention would be the bisphosphonates. Right? We have two major umbrellas of medications, the anti-resorptives, or those medications that slow bone breakdown, and the bisphosphonates are the most well-known in that category. And then we have another umbrella, the anabolics or bone-building medications, which by and large are probably not as readily prescribed by primary care physicians.
Mm-hmm. Should they be?
They have an absolute role in the management of osteoporosis. Should they be prescribed by primary care physicians? I think it depends on their comfort level. The recognition that there are other options and that perhaps if something else is more appropriate and I'm not comfortable prescribing, that's when I should refer to a specialist. I think that's as important as being able to write the prescription.
And where do calcium and vitamin D fit with all of this?
They are part of the management plan regardless of what one is prescribing.
Either with anabolics or with...
Yeah. All of the clinical trials for osteoporosis medicines have been done when patients have been supplemented with calcium and vitamin D. So some baseline level is important as part of the treatment plan.
And do your treatment approaches, this basic pharmacologic approach, in the presence, one would hope, of good exercise and whatever else, does it change based on age and fracture risk?
Yeah, so as Dr. Singer nicely pointed out, I mean, the bisphosphonates are the base, so it's the standard of care. So for patients who are older with risks, so you give me older age, multiple risks in a fracture, that's much more significant than someone 10 or 20 years younger without that, okay? We talk about risk, so somebody who's been treated and has fractures, maybe on prednisone, steroid medicine, and they've had problems or their T-scores are in a more worrisome range, that's typically the place for some of the other things that we're gonna be talking about. And what is hopefully going to emerge over the next decade, we talk about what is not in everyone's language in day-to-day care is kind of an individualized, goal-directed treatment approach, or how to use drugs in kind of sequencing. And it's these newer drugs that have different mechanisms of action that probably can afford that type of patient a better outcome.
Let's role play for a minute. I'm going to come to see you, and I won't call you a bonehead.
Thank you.
But I'll say, I'm of an age, pick an age, 65. I've never been tested. I'm a little worried. My mom had a fracture when she was 85. I'm female, if you will. What is your cocktail? How do you start? Just make believe you're taking care of a patient for the first time.
For the patient, if you've never been evaluated, never had a bone density test, given your age and risk from a family perspective, we should get a bone density test.
Okay, we get that. It comes back, it's worrisome. Now, never been treated.
And you've never had a fracture.
Never had a fracture. How do you start treating me?
Well, I look at the rest of your medical history. Let's, for argument's sake here, say that there aren't really any complicating factors. Okay, we would talk about the different options based on your risk level. The fact that you're 65 or above puts you at high risk. The older we get, the greater the risk for fracture. Let's say your bone density is really quite low and worrisome. Then we have to talk about the approach in terms of whether we want to start with an agent that is going to sort of build bone as opposed to one that maintains. A couple of comments there or corollaries in terms of the way I would approach this. I have a very open discussion with patients in terms of laying out the options that are there, talking about benefits versus risks, and importantly, the risk of not doing anything, right? Because that's the piece that we often forget to balance. The other thing is we need to make sure that people understand osteoporosis is a chronic disease. Just like diabetes, just like heart disease, I can treat this and control it and reduce risk. I can't cure it. So this is going to be something that we're going to have to manage for the rest of your life. Management can look like different things in terms of what drug we start with, what we then switch to. But it's not as though you treat for 2 years and you're better and I don't need to see you anymore.
No, it's not all gone.
Right.
Now,
It's not all gone.
You monitor me, all right? What would cause you to add other agents to the regimen we started with? What would make you switch?
It's not always or often an add, it might be a switch. That would be something that we would deem a true treatment failure. So what's a treatment failure? That sounds like an easy question, but it isn't. It might be somebody who has lost bone density, a significant amount of bone density, more than the inherent difference you would see in the machine, but it's a true bone density loss, right? Somebody who's, if you're following bone turnover markers, who's not responding the way one would expect. This is all assuming that you're taking the drug, you're taking it correctly, and nothing else has happened in the interim. What about the patient who's fractured, right? None of the medications we have available reduce fractures by 100%. So a single fracture doesn't necessarily mean treatment failure in the individual patient, although we don't like to see that happen. But if you've had more than one fracture, then I need to think about why is this medication not working.